So hi guys, let's come to the November INICET 2023 recall. Remember, this recall is purely based on the memory of students. Some of the options might not be exactly as in the exam. So these are just recall options which you should be knowing. Okay, so let's look at that. So blue color vacutainer for plasma glucose is with which anticoagulant? So this was a very unusual question that came and it's not correct. Okay, so whenever we talk about blue color vacutainer is typically trisodium citrate vacutainer, which is used for coagulation testing. Okay, so blue color vacutainer should not be used for glucose estimation. Glucose estimation is usually done with a gray topped vacutainer. So I don't know where was the discrepancy here. Okay, so whenever they ask you about blue color vacutainer, the vacutainer has to be trisodium citrate vacutainer. Okay, trisodium citrate vacutainer is a blue color coagulation vacutainer. It is used for the coagulation testing. That is what we all have to know. Okay, whereas for glucose estimation, basically we have sodium fluoride in it. Okay, so remember, nowadays we use EDT in it, and earlier days we used to use potassium oxalate in it. Okay, because both the options were given here, so that is why probably this is not a glucose vacutainer that they are asking. So they are asking blue top vacutainer, which is usually trisodium citrate for coagulation studies. So whenever we have to look at the vacutainers, we should be very clear in what order the sample has to be taken. This is called as order of draw. Why is order of draw important? Because if we do not follow this order of law, cross contamination can occur. Okay, cross contamination can occur because the first sample that you have to take is culture, and after that the second sample that you have to take is it should be of an anticoagulant which is not a permanent anticoagulant. For example, when I say a permanent anticoagulant, if that is added in a solution, nobody can reverse it. So this has to be taken at the end, at the last. Okay, so therefore EDTA is one of the permanent anticoagulant, and that is why it is preferred to be taken at the last. Okay, whereas trisodium citrate is a reversible anticoagulant. That means when you add calcium, its effect is finished. Okay, so that is the principle for coagulation testing. So immediately after culture, you should take trisodium citrate vacutainer, so that you once you add calcium, it will be reversed. Okay, so first you take culture always, then you take citrate always, and after once you have taken citrate, then you want a tube which does not have any anticoagulant. Basically, you want serum tubes. Okay, so that is serum. So serum tubes are non-additive tubes, so they have clot activators within them. Okay, so that they help in making the clot. Why? Because once the clot is formed, okay, so what is left on the top is serum. So this serum is used for various testings, various biochemical testings, your vitamin B12, your iron, all that is done on serum. Okay, so that is why serum is what is needed now. Then you use serum tube or non-additive tube. What is present in non-additive tube? It's a golden topped vacutainer, remember, and it has clot activator. Okay, so you can see these two tubes here. These are red and golden. What is the difference between both? Both are basically used for making serum. The difference between both is in the red topped vacutainer tube, you have clot activator, but it does not have separator, gel separator. It does not have gel separator. So what used to happen in earlier, when we used to take the blood in the serum vacutainer, it had clot activator, clot used to form, but because it used to take a long time for formation of clot, after a point of time what used to happen is sometimes in transporting of the sample, hemolysis used to happen. So then they devised this golden top vacutainer tube. So this golden top vacutainer tube has a clot activator and it also has a small gel within it. Okay, so what does this gel do is it separates the red cell from the serum. So these red cells do not cross contaminate the serum, and chances of hemolysis is also very less. That is why golden top vacutainer came into use and it became very successful. Okay, so both of these are serum tubes, but the difference I've already explained you. Okay, after that, once you've done CCS, you have to start again with heparin tubes. Okay, so heparin tubes, whenever I'm saying, this is your green top tubes. Okay, so heparin tubes are always green top tubes, and basically heparin, where do you use heparin? Heparin is basically used for your osmotic fragility test. Okay, and also it can be used for your IPT, that is flow cytometry. For flow cytometry, we can use either EDTA or heparin. Both can be used. Okay, so heparin can be used for flow cytometry. Apart from that, all your fish and your cytogenetics have to be done in heparin. Okay, all your fluorescent in situ hybridization, or if you have to do karyotyping or cytogenetics, that can be done on heparin tubes. Okay, so that is the utility of heparin tubes, which you all have to remember. So apart from osmotic fragility test, all your fish cytogenetics, okay, even flow cytometry can be done on heparin tube. Okay, and of course all of you know and that whenever we talk about the next tube, that is your EDTA tube, which is a lavender top tube. This is your EDTA tube, okay, lavender top tube, and this is one of the very strong anticoagulant. It is an irreversible anticoagulant, so it has to be taken near the end. And all your CBC, PS, okay, complete blood count, your peripheral smear examinations, your complete blood counts have to be done on your lavender top tubes. Apart from that, it is one of the very good anticoagulant which you have to use for PCR testing. Okay, so for PCR testing we preferably use your lavender top tubes. Okay, so that is for PCR. Remember, heparin should never be used in PCR because it will stop the process otherwise. Okay, so for CBCPS you have to use EDTA tube. For PCR you have to use EDTA tube. Also, it's one of the very good anticoagulant. It's the best anticoagulant for flow cytometry, and for flow cytometry also EDTA is one of the preferred anticoagulant which you should use. Okay, so that's your EDTA tube. And last, I told you gray color tube, that is your oxalate tube. Earlier days, we even add EDTA in them. It usually has sodium fluoride also in it because it inhibits enolase. Okay, and it is used for glucose estimation. This is your gray topped vacutainer tube, which you should remember. It has your oxalate and sodium fluoride, but EDTA and sodium fluoride can also be present in them, and it is used for glucose estimation. It is one of the last vacutainer tube to be used. Okay, so the order is very, very simple to remember. Always remember CCS. You have to first use culture, you have to use citrate, you have to use serum, and after that you have to use heparin, EDTA and sodium fluoride. Okay, so sodium fluoride, HEF. Okay, so CCS and HEF. Okay, that is how the order of draw is there. Okay, so that's the order that you should always follow, and if you know the principle behind it, you will never ever confuse it also, right? Okay guys, so that's your order of draw, which everybody should be super clear. Okay, so let's talk about this question again. Which of the following is the anticoagulant of choice in coagulation laboratory? So always remember, the anticoagulant of choice in coagulation laboratory is 3.2% trisodium citrate, that everybody knows. But the ratio of blood to anticoagulant is very, very important. Blood should always be more, anticoagulant should always be less. So anticoagulant should only be 1 volume and the blood should be 9 volume. Okay, so anticoagulant should be 1, blood should be 9. Okay, so it is 3.2% trisodium citrate in the ratio. Blood to anticoagulant ratio should be 9:1. So here please change the option. This is 3.5. Okay, right. So the answer to this question is A. Okay, so that should be clear to everybody. Coming to the next question here, which of the following are markers of seminoma? And the options were given. A lot of options were given. So PLAP, OCT3, KIT, NANOG. So remember, all 4 of them that has been given are the markers of seminoma. All the 4 are markers of seminoma. So whenever I talk about marker of seminoma, remember seminoma is one of the most common germ cell tumor, and the markers that we typically use for them is OCT3-4, KIT, NANOG, SOX17 and podoplanin. So these are very common markers which are used. So remember this, basically seminoma arise from germ cell neoplasia in situ, and these markers are basically marker of pluripotent cells. Okay, so that is why you have to remember them very nicely. So it has to be OCT3-4, KIT, NANOG. Okay, and you have to remember SOX also, which one? 17. Okay, 17 is 7 for seminoma. Okay, 17 is for seminoma. Okay, so these are common markers which are used for seminoma, which you have to remember, and it is negative for cytokeratin. So there are some markers which you should always know in some tumors, especially in the ovarian and testicular tumors. You have to remember, okay, some tumor markers. Alpha fetoprotein, if somebody asks you, you should remember it is yolk sac tumor and hepatocellular carcinomas. HCG is for choriocarcinomas, calcitonin for medullary carcinoma, CEA basically for colon, but it can be positive in other tumors also. CA125 is for surface ovarian tumors. CA199 is for pancreatic cancer. PLAP is basically for seminomas. Okay, prostatic acid phosphatase is prostatic carcinoma. PSA for again prostatic carcinoma. S100 is for many things. It's for melanoma. Okay, remember, cartilage tumors and nerve tumors. Okay, apart from the neuroendocrine tumors can also be S100 positive. So S100 is very non-specific marker, but it can be present in many things. Okay, melanoma, nerve cell tumors, cartilaginous tumor, and even neuroendocrine tumors. Okay, right. And TRAP is basically for hairy cell leukemia. So these are some common markers that you should always be knowing, and this is super important for us to understand. Also, you should remember seminoma has a very characteristic appearance. Okay, this is what is called as cut potato appearance, because it's a very homogeneous tumor and it bulges. So this is cut potato appearance. Okay, and if you look at the microscopy, there is septa, okay, which separates these tumor cells. You have to remember, and the septa are infiltrated by lymphocytes. So there are a lot of lymphocytes which infiltrate the septa. If you look at the individual tumor cells, they are polygonal tumor cells which have watery clear cytoplasm, large nucleus, and prominent nuclei. So these are very, very typical cells which you see here. Okay, so these are polygonal cells, okay, which have watery clear cytoplasm. So that's a very classical appearance of seminoma that you all have to know, and it's one of the germ cell tumors. Okay. Right. Coming to the question number 3, that was match the following. You have to match the following columns. Okay. So now first was how will you match it? So there was inheritance given and this was given. So always remember, mark the one which you know first. Look at the name here. This is Liebers. Any name like these, you know, Liebers or Melas or Murph. Okay, all these are very unusual names and they are very typical for mitochondrial inheritance. Okay, so I'm just writing it here. Murph, okay, myoclonic epilepsy and ragged red fibers, or myoclonic epilepsy and lactic acidosis syndrome. All these are mitochondrial inheritance and you don't have to be confusing this. Okay, then we come to the X-linked. Okay, so when we talked about X-linked recessive, you know, there are very few disorders which are X-linked recessive. If you look at the law, 2 hematological disorders are X-linked recessive. That is, remember, G6PD deficiency, okay, G6PD deficiency and hemophilia. Whereas in others also color blindness and Duchenne's muscular dystrophy are X-linked recessive. So Duchenne's muscular dystrophy and color blindness are X-linked recessive. So X-linked recessive disorders are well known and you should be knowing that. Okay, now we are left with the others. Okay, so now when we know all the inherited disorders of metabolism, whatever they are, usually are autosomal recessive. So cystic fibrosis is an inherited disorder, so it has to be autosomal recessive. However, exception to the rule is hereditary hypercholesterolemia and acute intermittent porphyria, which are basically autosomal dominant inherited disorders. But since there are only 2 or 3 of them, you don't forget them. Okay, so remember, cystic fibrosis is a classical inherited disorder, this inherited disorder, biochemical disorder, and it has to be autosomal recessive. Now you're left with the myotonic dystrophica. Myotonic dystrophica, basically now we know it is a trinucleotide repeat inheritance and it is autosomal dominant also, right? So that's how we've matched it. So if we quickly revise what we have started, so if you talk about X-linked recessive inheritances, we know that color blindness, you have to remember, especially red-green color blindness, which is also called as daltonism, is X-linked recessive. Hemophilia is X-linked recessive, and 2 muscular dystrophy, that is Duchenne and Becker, are X-linked recessive. Also, you should remember X-linked dominant disorders. One of them which everybody knows, vitamin D resistant ricket, is X-linked dominant. Rett syndrome, okay, although 95% are due to sporadic mutation, but once it's there, it's X-linked dominant inheritance. Then fragile X syndrome, okay, fragile X syndrome is usually X-linked dominant, but it can also have other inheritances, but majority of the time it's X-linked dominant. Then most of the cases of Alport syndrome is also X-linked dominant, and incontinenta pigmenti and Gault syndrome. Okay, incontinenta pigmenti and Gault syndrome. So these are some of the X-linked dominant disorders which they ask you in exam. So I've compiled a list so that you don't confuse and you know this better. Okay, now let's come to the autosomal recessive inheritances. All the inherited disorder of metabolism, whatever it is, okay, exception I told you, except acute intermittent porphyria and hereditary hypercholesterolemia. Okay, These are autosomal dominant. But what about others? All are autosomal recessive. That might be cystic fibrosis, hemochromatosis, Gaucher's, Tay-Sachs, Sickle, Thal. They are all autosomal recessive. Now, coming to the autosomal dominant inherited disorders, when we talk about autosomal dominant disorders, always remember two disorders in hematology, that is von Willebrand disease and hereditary spherocytosis, are autosomal dominant. Apart from that, Huntington's disease, Marfan syndrome, okay, myotonic dystrophy, all the, basically you have to remember all the neurological disorders and the polyps, okay, all the, just a clue to remember is all the neurological disorders and the polyps, okay, are autosomal dominant. So all the neurological disorders predominantly and polyps of the intestine. So polyps, majority of the intestinal polyps are autosomal dominant, and however the exception to the rule that you have to remember is basically your Muthi polyposis, okay, Muthi polyposis. So this is autosomal recessive polyp syndrome. All the other polyps, whatever polyps you think of, they are autosomal dominant. Okay. Apart from that, all the other polyps are autosomal dominant. Okay. So all the neurological disorders that might be Huntington's, Marfan, tuberous sclerosis, myotonic dystrophy, neurofibromatosis, all are autosomal dominant. Exception to the rules are Friedreich ataxia. Okay, exception to the rule of Friedreich ataxia. Okay, Friedreich ataxia is an autosomal recessive inherited disorder. Okay, so, or ataxia telangiectasia is also autosomal recessive inherited disorder. So ataxia telangiectasia and Friedreich ataxia are autosomal recessive. Rest all are autosomal dominant. And in polyps, all the polyps are autosomal dominant except Muthi polyposis, which is an autosomal recessive polyp syndrome. Okay, and apart from that, look at this condition here, acute intermittent porphyria. I told you this here itself, that acute intermittent porphyria is an autosomal dominant inherited disorder of metabolism, and that you have to remember. Okay, so these are the classical inheritances that they ask you, and you should be super clear with it, right? So guys, when we finished your X-linked inheritance and the autosomal inheritance defect, we should also be knowing mitochondrial genes, okay? So remember, we have only 37 mitochondrial genes. Out of these, 13 are for respiratory chain, okay? Apart from that, we are left now with 22, which are for transfer RNA, and 2 for ribosomal RNA. So that is how the mitochondrial genes are associated. So we have only 37 mitochondrial genes. So whenever we have a defect in the mitochondrial inheritances, it usually involves CNS, eye and nerves, okay? So majority of the patients usually have symptoms of CNS like epilepsy, or they have symptoms of eyes like retinitis pigmentosa or optic neuropathies, or they have neuropathy, some nerve problems, okay? So they have been given a particular name. So all the inheritances have been given particular name like Lohorn, okay, that is Leber hereditary optic neuropathy, or NARP, nystagmus ataxia, retinitis pigmentosa. You see, everything is involving eye, brain, like that. MRF, myoclonic epilepsy and ragged red fibers, Kehr-Seyre syndrome, myoclonic epilepsy and lactic acidosis syndrome, Pearson syndrome, or Leig's disease. All of these are basically inheritances of the mitochondrial genes, which we should always be clear. And you know, they always give you a pedigree or electron microscopy of mitochondrial inheritance. If you look at the electron microscopy of mitochondrial inheritance, it typically shows you these kind of inclusions, which are called as parking lot inclusions. Or they can show you these kind of records, which are called as phonograph records. So these are very typical electron microscopy of mitochondrial inheritance. And if you look at the pedigree, you look at this, when the mother is involved, all the children are involved. When the father is involved, none is involved. When again mother is involved, all the children get involved. So that's a typical pedigree of mitochondrial inheritance. Okay. So that's about mitochondrial inheritance, which everybody should be super clear about. Okay. Now, once we are very clear with the mitochondrial inheritance, now let's go to the next question. Okay. So the next question was a very interesting question. That was, which of the following is not involved in double-stranded DNA break repair? So DNA repair itself is a very interesting topic, guys. You should understand that whenever I talk about DNA repair, we have three types of mechanism of DNA repair. One is called as nucleotide excision repair. Then we have mismatch repair. And then we have recombinant repairs. So whenever I'm talking about these three mechanisms of repair, remember nucleotide excision repair is a typical repair defect, which is basically seen in your xeroderma pigmentosa. Okay, so this is basically a nucleotide excision repair defect, okay, which is seen in xeroderma pigmentosa. Mismatch repair defect is a type of repair which is, when defective, causes microsatellite instability. Okay, and this is very typically seen in hereditary non-polyposis colon cancer syndrome, which is also called as Lynch syndrome. Now, recombinant repair defects basically involve your double-stranded DNA repairs. So, majority of the recombinant repairs are because of DNA repairs, double-stranded DNA repair. So, these usually have a syndrome which is very typically called as FAB. Okay, that is Fanconi anemia, ataxia telangiectasia, and Bloom syndrome. So, Fanconi's, ataxia telangiectasia, and Bloom syndrome. Now, we have seen here Fanconi. So, Fanconi basically has involvement of, it has BRCA genes which are involved. So, these BRCA genes can basically cause homologous DNA repair also and non-homologous DNA repair also. Now, ataxia telangiectasia has a gene called as ATM. Okay, so this gene also, ATM, is also involved in DNA repair, usually non-homologous end repair. Okay, so Bloom syndrome, the gene is not given, so we don't need to worry about it. Okay, so remember, BRCA DNA repair karta hai double stranded, ATM double stranded repair karta hai. Now we are left with two options, okay, MSH2 and Q70 or KN70. Now we are in doubt, but we know very particularly that microsatellite repair genes are basically your MSH genes. Okay, so MSH2 or MSH6, these are your micro satellite repairs or mismatch repair genes. Okay, so these MSH2 or MSH6, these genes are very important mismatch repair mechanisms. Okay, and they are not involving double stranded DNA repair. They're not involving double stranded DNA repair. So if you look at this, definitely this is not helpful in double stranded DNA break repair mechanism. Okay, this is basically involved in mismatch repair mechanisms, not in double stranded repair. Okay, so this is definitely a different subgroup of repair. Whereas Q70, even if we don't know this, we should know that this Q70 is helpful in double-stranded DNA repair. Obviously, it belongs to the same category, okay? So, this basically goes to the double-stranded DNA and helps in the repair. So, this also helps in double-stranded DNA repair. So, which is not helpful in double-stranded DNA repair? So, answer should be MSH2. Remember, MSH2 is not helpful in double-stranded DNA repair. That's the answer to this question, and you should be super clear with it. But remember, MSH2 is basically microsatellite repair mechanism, mismatch repair mechanism, and its defect causes Lynch syndrome or microsatellite instability. Okay, so is everybody clear with this? So you should be super clear with the DNA repair mechanism. Remember, MSH2 does not cause your double-stranded DNA repairs. Okay. Now let's come to the next question. So this is a 47-year-old male who has decreased urine output for 24 hours, and histology RPGN was seen, rapidly progressive glomerulonephritis was seen. You know, this will show you crescents, but with pauci-immune glomerulonephritis. So this is a catch here. It was pauci-immune glomerulonephritis. So the crescents are there, but it's pauci-immune. So they have asked you what is the main etiology of this. Okay, so this is a super easy question if you understand the mechanism. So whenever I talk about, RPGN, you all know that we have three type of RPGNs, 1, 2 and 3. Okay. So we have type 1, we have type 2 and we have type 3. Okay. So type 1 is basically due to anti-GBM antibody. Okay, anti-glomerular basement membrane antibody, which will directly cause break in the basement membrane and it will cause crescent. Hallmark of crescentic nephropathy is always break in the basement membrane. Type 2 is always due to immune complexes. Okay, so any immune complex mediated disease will cause type 2 RPGN. Type 3 is basically your pauci-immune. Okay, so pauci-immune, there is no immune complex there, but it is due to circulating antibodies, that is ANCA antibodies, okay, which can either be P-ANCA or it can be C-ANCA. Okay, so that is anti-neutrophil cytoplasmic antibody. So these antibodies are targeting the granules of the neutrophil. Okay, so P-ANCA basically targets your MPO and C-ANCA basically targets your proteinase 3. Okay, so this is pauci-immune. Okay, so now the question is, pauci-immune glomerulonephritis, which has which antibody? So obviously pauci-immune has ANCA antibodies. You should be very clear with that. So now you know if it is Posse-immune, it has to be ANCA. Anti-GBM antibody, if they ask you type 1, then it is anti-GBM. ANA, immune complex mediated diseases, even in SLE, if somebody develops PSGN, it can be type 2. So ANA agar diya hota, to type 2 ho jata. Okay, anti-PLA2R is basically is an antibody which is seen in membranous nephropathy. Okay, so it is a membranous nephropathy that you should remember. It's for membranous nephropathy, which should be super clear with, right? So that is anti-PLA2R, which everybody should be knowing. So the answer to this question is ANCA, and there should be no doubt on that. Okay. Now this is a crescent. If you look at this is a glomerulus, and there is a crescent here in the periphery. Here you can see this is a crescent, and it has to be crescentric glomerulonephritis. Very nice. Okay, let's go to the next question. So which of the following stains cause brown color to HER2-neu cells of breast cancer? Remember, HER2-neu typically causes membranous positivity. Okay, so that can also be a question next time. Okay, so it is always membranous positivity. And whenever I'm talking about immunohistochemistry, the stain that gives brown color, I keep teaching this again and again. This is called DAB. That is diaminobenzidine. Okay, so DAB is the molecule which gives you brown color. Okay, so it is diaminobenzidine that you have to remember. And I don't know what is FCH. It should be actually FITC basically, if I am clear. So FITC and phycoerythrin are basically the very important color dyes which we use in flow cytometry. Okay, so these are used in flow cytometry. FITC is also used in immunofluorescence. Okay, it's also used in immunofluorescence. So that should be very, very clear. FITC is a green color dye. Okay, so it's used in your immunofluorescence. Phycoerythrin is a red color dye. Okay, so very commonly used in flow cytometries. Okay, DAB is a brown color compound. It is used in immunohistochemistry. Okay, so that should be super, super clear with everybody. Okay, so now this is a very classical thing that they've given. There's a 26-year-old female with bleeding disorder who gave history of father. Okay, so the father also has the disease. Okay, and there are two sisters, let's say. Okay, so sisters also have the disease. Okay, so father also has the disease. Okay, sister also have the same bleeding disease. This girl is also having the disease. Okay, so what are the most likely diagnosis? So whenever father is also having the disease and the daughters are also having the disease, so we should think, so what all can be the possibilities? The possibilities can be either it is an X-linked dominant disorder. Okay, either it is an X-linked dominant disorder, or it is an autosomal dominant disorder, which is in which the father is involved, and because that might be a dominant allele, so it has gone to the daughters, so daughters are also involved. It might be that they would have given the son is also having the disease, then also you would have thought the same answer. So from the history that is provided, I can give a clue that either it is an X-linked dominant disorder or it is an autosomal dominant disorder. Okay, so hemophilia A is an X-linked recessive disorder. So if when it is an X-linked recessive disorder, the females should not be affected. So this is out. Christmas disease is hemophilia B. Again, it is an X-linked recessive disorder. So females should not be showing the disease. Okay, factor 12 deficiency is autosomal recessive disorder. So it should not be that the father is affected and all the daughters are also getting affected. So two of the daughters at least are getting affected. 50% of the progeny is getting affected. Again, doesn't fall into this rule. So von Willebrand disease is an autosomal dominant inheritance. So yes, from the history provided, I can say that yes, it is an autosomal dominant inheritance, and this can fit into the diagnosis. So yes, it's an autosomal dominant inheritance, which can be von Willebrand disease, right? So that is the answer to this question. Okay. Next was which is not a criteria of metabolic syndrome. Exactly, I don't know the exact options that were provided. So I gave you a chart. What is a criteria for metabolic syndrome? So according to the WHO, okay, the criteria of metabolic syndrome, we have either one of the patient should have either frank diabetes mellitus, okay, or he should have impaired glucose tolerance test, or he should have impaired fasting glucose test, or he should have documented insulin resistance. Okay, so either he has diabetes, or there's an impaired fasting glucose, or there's an impaired glucose tolerance, or he has insulin resistance. So any one of the following can be there. Plus two of the following, and so along with that there should be two of the following. So remember what two of the following should be there. It's a very, very simple thing that you should remember. This is DOPA. Okay, so any two of the DOPAs. Okay, so what is D? D is dyslipidemia. Okay, so first there should be dyslipidemia. How do you assess dyslipidemia? Either the triglyceride should be high or your HDL should be low. Okay, so either your triglycerides are high or your HDLs are low, then you will say that there is dyslipidemia. So both the criteria can be used here. Okay, so this and this. Okay, so triglycerides are high and your HDLs are low, then it is dyslipidemia. Okay, because any one of the following alone, like some people have hypertriglyceridemia but HDLs are within normal limits, so that is not dyslipidemia. Okay, so both should be there. Okay, now that is dyslipidemia. O is central obesity. Obviously when the lipids are abnormal, there is high chances of getting obesity. So central obesity. So how do you assess central obesity? Either you take waist to hip ratio or you take body mass index. So if the body mass index is more than 30, if the BMI is more than 30, or waist to hip ratio is more than 0.9, okay, more than 8.5 in females, more than 9 in males. Okay, more than 0.9 in males. So either you take waist to hip ratio or you take body mass index. Okay, so waist to hip ratio is more than 0.9 in males, 0.85 in females, and your BMI is more than 30, then also it comes under that category. Okay, then P is pressure. Okay, blood pressure. How much? 140/90 se zyada, more than 140/90. So that is blood pressure. And A is albuminuria. It should be microalbuminuria. Okay, microalbuminuria. So either you take urine albumin, which is more than 20 microgram per minute, or you take albumin to creatinine ratio. That is also very good marker. And this is more than 30 milligram per gram. Okay, more than 30 milligram per gram. So albumin is coming in the urine. It is microalbuminuria usually. So either you take albumin excretion that is more than 20 microgram per minute, or you take albumin to creatinine ratio, okay, which is more than 30 milligram per gram. So any four of the following, so any two of these four I require. Out of DOPA I require two. Either the lipids are dyslipidemia and obesity is there, or blood pressure is there, and microalbuminuria is there. So any two out of these four. So I require one of the symptom plus two of these features. So that is basically a typical criteria for metabolic syndrome, which everybody should be super clear. Okay, so now let's come to the options. So I do not know what was the exact option, but looking at that, I find that HDL, yes, and triglycerides are very important part of your dyslipidemia. Blood glucose is very important. It's one of the major criteria which you have to remember. Then hip circumference. I don't require hip circumference. I require waist to hip ratio, or I require a body mass index. Okay, and of course BP more than 140/90 is a mandatory criteria. Okay, so according to this, hip circumference is usually not taken. So remember, that's the metabolic syndrome. It's a very easy way to remember. One of the feature of diabetes or impaired glucose tolerance, or your impaired fasting, or your insulin resistance, plus you require two of the dopas: dyslipidemia, obesity, pressure, and microalbuminuria. That's it, done. So that is the criteria for metabolic syndrome, which everybody should be super clear, right? Let's go to the next question. Serum transferrin saturation is low, and this is very easy. See, whenever your iron levels in the body are low, automatically the transferrin saturation is also going to be low. So iron deficiency anemia is a very simple stat answer where the transferrin saturation is low. Transferrin saturation is low. Hemochromatosis is iron excess, so transferrin saturation is high. Hemosiderosis is iron excess, so transferrin saturation is high. Pernicious anemia is a B12 deficiency, nothing to do with iron, so transferrin saturation will be normal. Okay, so that is why iron deficiency anemia is a condition where your transferrin saturation will be low. Okay, for that instance, even in anemia of inflammation or anemia of chronic disease is now known as anemia of inflammation, transferrin saturation will be low. Now, there is a vegetarian patient whose MCV is 110, hemoglobin is 10. What is he most likely going to have? See, whenever your MCV is more than 100, it means macrocytic anemia. So you just have to see out of the given condition which of the following is a macrocytic anemia. Okay, so iron deficiency is a microcytic anemia. Okay, so now Again, we have to see thalassemia is also a macrocytic anemia. So now we are left with two conditions, aplastic anemia and megaloblastic anemia. Both can be macrocytic. Okay, so aplastic can also be macrocytic and megaloblastic anemia can also be macrocytic. So now the clue, we have to look at the clue. So the clue that is given, he's a vegetarian patient. So that's a strong clue. Vegetarian patient means that there will be B12 deficiency. So probably they're looking at the answer of megaloblastic anemia, and that is why the answer should be megaloblastic anemia. Remember, aplastics are also macrocytic, but they usually don't go up to 110. Okay, so macrocytic, like that will be like 100, 100, 200, 305, like that. But here the clue is vegetarian. So that's the clue to the answer. So that's why megaloblastic anemia should be the first point you should remember here. So remember, macrocytic anemia can be megaloblastic, or it can be non-megaloblastic. Non-megaloblastic, the important ones you have to remember are liver diseases, aplastic anemias, hypothyroidism, okay, right? And these are the common causes. Okay, these are the common causes which are non-megaloblastic causes of macrocytic anemia, and megaloblastic is separate category, which is because of vitamin B12 and folic acid deficiency. Right, so that is your macrocytic anemia, which everybody should be clear. Okay, so whenever we talk about these sickle cells, no, here, okay, so you should remember that sickle cells, what happens is, after a complete cycle of reversibility and irreversibility, the membranes get damaged. That is why they have very high mechanical fragility. Okay, so they are very fragile cells. They will rupture quickly. They have very fragile cells. So much so that when they rupture in the circulation, the hemoglobin is released and it can cause, damage. Okay, so that is very important that you have to remember. The mechanical fragility of these cells is very, very high. Now, the point is, what about the osmotic fragility? See guys, when we talk about spherocytes, okay, so spherocytes basically are cells which do not have a central pallor. So what is going to happen is that they are going to take in more amount of, whenever they were going to keep them in a solution, they will not be able to absorb water. Why? Because there's no space for them. So that is why, even if little amount of water will go inside, they will rupture. So this is called high osmotic fragility. Okay, so the osmotic fragility of sickle cells is very, very high. They will rupture even with small amount of water going in. Now, what about sickle cells? So when we talk about sickle cells, okay, so what is going to happen in them is that they are already sickled, their membranes are already damaged. So if you keep them in a solution, they will keep on taking more and more water. Why? Because they are very dehydrated cells. So because of the pump dysfunction, they are dehydrated. So they are dehydrated cells, so they can take more water. So just like microcytic hypochromic cells, which have a lot of space and they can take in more water, sickle cells are also dehydrated cells. The membranes are not working well, so they keep on taking more and more water into that sickled area. So their osmotic fragility is low. So everybody should be clear about this point, that sickle cells are very mechanically fragile cells. This is because the problem in sickle cell anemia is decreased solubility. Okay, so these sickle cells, they bind with one another. To form sickled cells. So they're very fragile cells because their membranes are already damaged. So a little bit of more trauma, they'll get ruptured. So they are mechanically very, very fragile, but their osmotic fragility is low, because even if you keep them in a solution, they'll keep on taking more and more water within them, and they'll survive. So osmotic fragility of sickle cells is low, but mechanical fragility of sickle cells is very, very high. So that's a point that everybody should be super clear with, right guys? Okay. Now, let's go to the next question. Which technique is used to identify autoantibodies? See guys, whenever we have to identify the autoantibodies, okay, autoantibodies means circulating bodies. So autoantibodies, okay, circulating autoantibodies, so they can be picked up by two ways, okay. So what are the two ways of picking up circulating autoantibodies? Circulating autoantibodies, when they're circulating in the blood, Okay, so you have to fix them on some substance and then you have to put fluorescence on them. So this is called as indirect immunofluorescence. Okay, so you can pick them up by indirect immunofluorescence. Or the other way of picking up any circulating autoantibody. Okay, so question is identify. Okay, so identification indirect is useful, but if you have to quantitate how much antibody is present, for quantitation we will do ELISA. For quantitation we can do ELISA. So for identifying that autoantibody, which autoantibody is present, is it present or not present, we use indirect immunofluorescence. For quantifying how much autoantibody is present, we use ELISA. Okay, so whenever we are talking about which technique is used to identify the circulating autoantibodies, it is indirect immunofluorescence. Okay, so the best answer to this question is indirect immunofluorescence. Now they have given you this image. This is a tissue, okay, on which you are doing this. So whenever you do it on tissue, it is called direct immunofluorescence. Whenever you're doing it in the blood, circulating antibodies, it is indirect immunofluorescence. Okay, so that should be very, very clear. So whenever you're doing it on skin, on kidney, tissues, it is a direct immunofluorescence. When you have to identify circulating autoantibodies, it is indirect immunofluorescence. Now, if they give you this figure and ask you that which technique is shown here to pick up antibodies, okay, so if this image was given, okay, so whenever they give you this image, that is they have done it on tissue, then it is basically your direct immunofluorescence. So you have to see what was the exact recall question, because I got 3 recall questions in it. First was they've given a tissue, they've given this green dye on it, and they have asked which technique is this. If they're doing it on the tissue, it is direct immunofluorescence. Which technique is used to identify circulating autoantibody? Then circulating means indirect immunofluorescence. Which technique is used to quantify the antibodies? Then the answer to that question is ELISA. Okay, so what about fish? Fish basically goes to the DNA levels. Okay, so in the DNA level, when you have to see the amplification, deletion, translocation, for that we use fish. Okay, so that's the answer to each of the option I told you. So think what was the question and answer according to that. Okay, so if it's tissue, it's direct. If it's circulating, it is indirect immunofluorescence. If it's quantification of antibodies, titer of the antibodies, then it is ELISA. Right. Next question is, which is the stain used for cervical smear? So this is the cervical smear that is given, and you can see this, it is basically a liquid based cytology, in which, because you can see that it is a perfect rounded circle, it's a liquid based cytology, and students got confused which stain do we use for liquid based cytology. Guys, for any cytology, okay, for any exfoliative cytology, the stain that is preferred is always Papanicolo stain. Okay, so just a brief about Papanicolo stain that I have to tell you. Okay, so brief about Papanicolo stain you have to know is that Papanicolo stain is a very important stain because it is made up of acidic and a basic component, and it can give various tinges, various colors to various component of the cell. So if you look at the Papanicolo stain, basically we use 5 dyes but 3 solutions. So we use 5 dyes but 3 solutions. So the first and most common stain that we use is hematoxylin. All of you know hematoxylin is a blue color dye, and this belongs to DNA sulfate group because it binds to the chromatin. It has a very high affinity to the chromatin, so it gives the blue color to the chromatin. And remember which hematoxylin is used in Papanicolo stain. Preferably we use Harris hematoxylin or Gill's hematoxylin. So these are the hematoxylins that we use. Okay, so beyond the scope of your undergraduate, that which kind of which are the 2 types of hematoxylins, just remember Harris and Gill's are most commonly used here. Okay, that's a hematoxylin. Now, second important dye that we use is orange green G. Okay, so orange green G 6, orange green 6. It is also called as, very popularly you must have studied, OG6. Okay, so this is orange green 6, OG6. If you look at this, this is an acidic counter stain. This is a acidic counter stain, and basically it stains the so orangish green 6. That's it. It gives this. It stains the cytoplasm of mature keratinized cells. So that is why the mature keratinized cells can have an orangish color in the pap stain. Okay, so this is basically the acidic counter stain that we use because hematoxylin is blue. Now you have to put a counter stain on it. So first counter stain that we use is OG6, which is orange green 6, and it stains the cytoplasm, okay, of mature keratinized cells. Okay, so that is your OG6. The third dye which we use is your eosin azure. Okay, so what is that called as? Eosin azure. very popularly called as EA. Okay, very popularly called as EA, eosin azure. This is a second counter stain. So that was orange. This is eosin, that's pink, and azure. So what all we had in this is, one is eosin. Okay, so one is eosin, and this is eosin Y. This is eosin Y. Okay, so basically this eosin is pink, so it is for mature squamous cells. Okay, cytoplasm of the mature squamous cells. Okay, apart from that, it stains the nucleoli also. Nucleus is by hematoxylin. Nucleoli, okay, eosinophilic nucleoli can be stained with your eosin Y. Red blood cells and cilia. So it gives, the red blood cells are also pink in color. The cilia are also pink in color. Okay, then we have eosin azure. Something has to give blue color, so for that we use light green SF. Okay, so this light green SF, we add light green SF. This basically stains the cytoplasm of the cells, and it basically gives blue color. Which color does it give? Blue color. So it stains the cytoplasm of parabasal squamous cells, columnar cells, intermediate squamous cells. So it gives that blue color to the cytoplasm. Okay, whereas hematoxylin is giving blue color usually to the nucleus. Okay, now third is Bismarck brown. Bismarck brown Y is usually doesn't give any color. It's not stained, but we add it. Okay, so this is the 5 dyes that we have used. First is hematoxylin, then OG6, then we have used eosin Y, then we have used light green SF, and we have used Bismarck brown. Okay, so these are the 5 important dyes that we have used in your Papanicolo stain. Okay, apart from that, you have to remember always, guys, so this together, these 3 dyes together, mixture of eosin Y, light green SF, and Bismarck brown, is called as eosin azure, and the most commonly used is eosin azures are EA31, EA50, and EA65. These are the most commonly used stains. Okay, so we have these are eosin azures that we use. Okay, now so EA50 is very common one which we use basically. So if somebody asks you how do you then stain, how do you make a staining for the Papanicolo stain, it's very easy. You have to just use these 3 dye. So first what you do, you fix the smear. Okay, so usually the fixative for any cytology is 95% ethanol. You fix it for 15 minutes. After that you add, first you dye, add hematoxylin. Okay, so first thing you do is hematoxylin you add, okay, for 1 to 3 minutes. Okay, in between every step we have to rinse. Okay, in between every step we have to rinse. So after fixing, we rinse it with tap water, then we put it in hematoxylin. Okay, after staining with hematoxylin, we then again rinse it with water, and then we put it in alcohol also. So we have to little bit dehydrate it. So we put alcohol, 95% ethanol, for 10 dips we give. After hematoxylin, what was the next dye? All of you know, orange G6, OG6. Okay, so then we add OG6. So we have added hematoxylin, now we add OG6 for 1.5 minutes. Now we have already dehydrated my 95% ethanol. Now we have, again we'll dip in 95% ethanol, and we will take it to 100% ethanol. So 95% ethanol, 100% ethanol for 1 minute. After that we'll add the third dye, that is eosin azure. So we will add eosin azure, whichever you want, eosin azure 50 or eosin azure 65. Okay, for 2.5 minutes. After that, that's it. Clear in xylene and mount. That's it. So procedure for pap stain is very easy. For you, for an undergraduate, just remember the 3 dyes and you're done. You use hematoxylin, you rinse it in alcohol. You then after that you add your orange G6, you rinse it in alcohol and 100% alcohol, and then you put the EA, eosin azure, and then you're done. Clear and mount. Okay, so that's how we do it. That's the staining, and this we can see various colors that we get. So you see this pink colored squamous cell. Okay, so this polygonal pink color squamous cell with a pycnotic nuclei. This is a superficial squamous cell. The nucleus is blue because of hematoxylin, and pink color you see, you know, eosin azure is giving you that pink color. Okay, can you look at the blue color in the cytoplasm with again a polygonal cell with little big nucleus? You know this is an intermediate squamous cell. Again the cytoplasm is blue because there is because of eosin azure complex complete. You already know we have light green SF which gives the blue color here, so it's giving the blue color, and the nucleus is getting blue color by the hematoxylin. And you can see the difference between this blue and this blue. Okay, because there is a different dye that is used. So nucleus is stained by hematoxylin, whereas the cytoplasm is stained by light green SF. That is why the blue shades are different. Okay, similarly if you look at these are parabasal cells. You can see the nucleus is very different. It is by hematoxylin, and the cytoplasm is by light green SF. Apart from that, parabasal cells are rounded cells, which you saw in this image. They are perfectly rounded cells. Okay. Now look at these cells. You can see these cells here. So they have inky chromatin. The chromatin is very, very dark. So they have inky chromatin. But the cytoplasm, if you look at them, it has a little orangish color which is coming here. Okay. So this orangish color, you know that this orange color, excessive orange color, indicates your mature keratinized cells, and with inky chromatin, okay, dark inky chromatin, this is very, very characteristic of malignant squamous cells. So this is a malignant squamous cells, that is, this is a keratinizing squamous cell carcinoma seen in the pap smear. So it's very easy, it glares your eyes, these orangish cells are catching your eyes, you know, seeing them identifies that yes, these are keratinized squamous cells, and you know this is a keratinizing squamous cell carcinoma in the pap smear. So that makes your diagnosis. So everybody should be super clear with this, and that's your diagnosis of pap smear. And these are the dyes of the pap smear that we have to know. Okay, so they can ask you any aspect of the pap smear, and you should be super clear with this. Okay, so apart from the lesions of the pap smear that they can ask, these are the basic staining practices of pap smear that can be asked. Okay. Now let's go to the next question. What is the most important prognostic factor of breast cancer? All of you know that lymph node metastasis is one of the most important prognostic marker, most prognostic status, and that is why we do sentinel lymph node mapping. That is the first lymph node to which the cancer has spread. If the sentinel lymph nodes are involved, we know that the cancer has spread to the lymph node and the surgery has to be extensive. So lymph node metastasis is the most important prognostic factor of the breast cancer. Okay, so which of the following with increase in size on electrophoresis? So it is increase in nephrotic syndrome. So this is an image, this is a jinx question which I had posted before the exam also. This is one of the graph which everybody should know, and you all know that when we talk about negative acute phase reactant, albumin is a negative acute phase reactant which will decrease in all the inflammation. So it's out. Okay, so when we talk about nephrotic syndrome, we have got at this, we all know that alpha 2. Okay, so all of you know that whenever I have to look at the electrophoresis, serum protein electrophoresis, that's how I make it. Okay, so the first band is albumin, then we have alpha 1, alpha 2, beta, and then we have a gamma, which is a big band. Okay, so normally albumin decreases, normal albumin decreases, but alpha 1, alpha 2, beta, and gamma is there. Gamma is like a hump. So whenever we talk about nephrotic syndrome, alpha 2 increases. Okay, so when we talk about nephrotic syndrome, alpha 2 increases. Okay, so alpha 2 increases in nephrotic. Okay, so nephro is basically your alpha 2. Okay, that is very, very clear to be remembered. Okay, so remember alpha 1, alpha 2, beta, and gamma. Now look at this. When the beta and gamma bridge together, they become friends. This is cirrhosis. So in cirrhosis, okay, so in cirrhosis, beta and gamma bridge together. So cirrhosis is formation of nodules. Okay, so people join together. So beta and gamma join together in cirrhosis. Okay, whereas you all know whenever there is an M spike, this is myeloma. This is a spike in M, so this is myeloma. Okay, so these are some things which all of you should be knowing. Okay, now so what is the thing which occurs in nephrotic syndrome? Always remember alpha 2 increases. Okay, so alpha 2 increases. Okay, so remember albumin, alpha 1, alpha 2, beta, and gamma. So if alpha 2 increases like this is your nephrotic syndrome. Okay, so kidney messes with your life, it's nephrotic syndrome. Alpha 2 increases, beta and gamma sticking together is a characteristic feature of cirrhosis, that is cirrhosis. Okay, so that should be super clear with everybody here. Okay, now next question was identify the following. Okay, so again, this is a very simple question. If you've understood the lectures properly, you will know this question and you'll be able to answer this question very well. Okay, so whatever they have marked, I don't know, some people say respiratory bronchiole, some of them were saying terminal bronchiole. So it's very easy. Let's understand the concept first. Okay, so the concept is very, very simple. So the main component of the lung is acinus. Okay, so main component of the lung is acinus. Okay, acinus is made up of respiratory bronchiole, alveolar duct, and acinus. Okay, that is alveoli. So RDA. Okay, so this is basically resident doctor association, RDA, which makes the acinus. Okay, it's a very close knit group. Okay, so we have respiratory bronchiole, we have alveolar duct, and we have alveoli. So all are closely intermingled with each other. Okay, so we have respiratory bronchiole, we have alveolar duct, and this opens into alveoli. And this on the top is a terminal bronchiole which is coming. So terminal bronchiole comes, and from that comes your acinus. In in acinus we have respiratory bronchiole, we have alveolar duct, and then acinus. So it should be very clear, some things are very, very clear, that whenever we talk about respiratory bronchiole, it has to be very closely connected with the alveoli. So if it is a respiratory bronchiole, it has to be connected with some of the alveoli. So if they are showing you a diagram where it is attached to the alveoli, it has to be respiratory bronchiole. Okay, whereas terminal bronchiole has a very thicker wall. Okay, so the lining epithelium can be columnar or locuboidal, but it is not attached to any alveoli. It is not attached to any alveoli. Let's look at the diagram. Okay, so this if you look at this is your terminal bronchiole. Okay, so this is your terminal bronchiole which is coming. So it's a closed, it's a columnar to cuboidal lining. Once it lining becomes thinner and it starts becoming attached to the alveoli, you know that we are turning into a respiratory bronchiole. Let's look at better diagram. So you can see this thicker wall coming out here. This is your terminal bronchiole. As soon as it opens here, the wall becomes thinner and it starts opening into the alveoli. It becomes respiratory bronchiole. Okay, so now somebody can ask me, ma'am, then how to identify alveolar duct? See, alveolar ducts are thicker and they don't usually have lining epithelium. So before opening into the alveoli, they have a thickened channels, which are thickened just air channels which are there, doesn't even have a lining. So that is an alveolar duct. So alveolar ducts are just thicker channels which opens into the alveoli. Okay, so remember, whenever they are giving you a diagram of a thicker channel which is not connected to alveoli, this is terminal bronchiole. When they are giving you this channel, okay, which is connected to the alveoli, it has to be respiratory bronchiole. Okay, so that should be super clear with everybody. So when we talk about alveoli, again alveoli is lined by type 1 and type 2 pneumocytes. So type 1 pneumocytes are just flattened epithelium like this, and you should remember that type 1 are basically your squamous epithelial cells. Okay, and just adjacent to this we have capillaries, whereas type 2 pneumocytes are basically your cuboidal to columnar epithelium, okay, which basically has the responsibility of secreting surfactant. Okay, so that's your alveoli which you all have to remember. So that's how we can make a easy connection. So remember, this is a terminal bronchiole here, not connected to the alveoli. Then when it's going down and getting connected to the alveoli, it is becoming a respiratory bronchiole. Alveolar duct is just thickened channel just opening into the alveoli. It doesn't have a well-defined lining also. Okay, so that is an alveolar duct. Okay, so you should be very, very clear with these. These are terminal bronchiole, respiratory bronchiole, and your alveolar ducts. You should be very, very clear with it. So depending upon the question what was marked, if it is connecting to the alveolus, it has to be respiratory bronchiole. If it is not connected to the alveolus, it's a thickened epithelium, then it is a respiratory bronchiole. Okay, right. So bronchus is very clear. It will have cartilage. You don't have to confuse with that. Alveolar sac we have already seen. It's just an alveoli with thin lining. That is alveolar sac, right? So whatever was marked in the exam, that has to be marked. Most probably, as far as I have got the feedback from student, it was respiratory bronchioles that was given. Okay, so it was connected to the alveoli. So that's the answer. Let's come to the next question. So the patient presents with a history of tuberculosis. History of the pathology is shown below. You can see a lot of Langerhans giant cells, which is a cytokine which is involved. All of you know that in TB, Th1 cells are activated, which release interferon gamma. These are the ones which will change the macrophages into epithelioid cells. Into epithelioid cells, and this will form the granuloma. Okay, so that is your interferon gamma, right? So that is your very classical appearance. This is your the interleukin, the interferon which is associated with tuberculosis. Okay, and you all know this is type 4 hypersensitivity reaction. Let's go to the next question. Match the following. So this was again a very easy question if you have understood your genetics and neoplasia well. So remember, again, focus on the thing that you know. So JAK2, all of you know, is a very classical involved with polycythemia vera, which is a myeloproliferative neoplasm. So C is 4. That solves the answer. Okay. GIST is KIT. So that also everybody knows. So most common mutation of GIST is KIT. So that also everybody knows. Okay. Now let's come to the next thing. Okay. So pancreatic cancer. So most common gene to be mutated in pancreatic cancer is KRAS. Adenocarcinoma of lung. Okay. Again here there was a catch here. Okay. So adenocarcinoma of lung can also have KRAS mutations. It can also have RAS mutations. But you have to remember that KRAS is one of the most common pathogenetic mechanism behind pancreatic cancer. Whereas in adenocarcinoma of lung, we can have either EGFR or we can have KRAS, which are mutually exclusive, or we can have ALK mutations. So these are three common mutations of adenocarcinoma of lung. So since this was given. So adenocarcinoma should be ALK, because in pancreatic ALKs are usually not seen. Okay, so that was the classical match that everybody should be very clear with. Okay, so that is how we should be remembering. There's some genes which you should be knowing. Okay, so KRAS is the most commonly dominant gene in the cholangiopancreatic region, cholangiocarcinoma, pancreatic cancers. Okay, KIT is basically just polycythemia myeloproliferative neoplasm is JAK2, and ALK is most commonly mutated in inflammatory myofibroblastic tumor, but it can also be seen in adenocarcinomas of lung. It can also be seen in anaplastic lymphoma, large cell lymphomas. Okay, so ALK mutations are very important mutations which you should remember. Okay, next, identify the histology in 75-year-old women with diabetes and hypertension. Okay, so here, no, you can see these bizarre, irregularly shaped nucleus like this. Okay, so these bizarre irregularly shaped nucleus here. So these nucleus are called ninja star nucleus. What are they called as? Ninja star nucleus. So irregular, haphazardly oriented nucleus is basically a ninja star nucleus. This ninja star nucleus is whenever these nucleus are more than 5%, they are very, very characteristic of titin mutation. They are very, very characteristic of titin mutation. So if you look at this, remember, whenever we talk about dilated cardiomyopathy, 50% of the cardiomyopathies can be genetic, okay? And we can have acquired causes also, but 50% of them are genetic. And they can have all sort of inheritances, but majority of the time, autosomal dominant inheritance is most common. And when we talk about autosomal dominant, 20% of them have TTN gene mutation, which codes for titin. So whenever we have titin mutation, usually the nucleus becomes haphazardly oriented, which is called ninja star nucleus, but it should be present in at least more than 5% of cells to call it as a ninja star mutation. Okay. Apart from that, remember, there can be other inheritances also of dilated cardiomyopathy, like mitochondrial inheritance can be there, which is seen in pediatric age group, or it can even be X-linked inheritances, which is basically seen in puberty to early adulthood. And usually they have mutation of dystrophin gene. So I hope you remember Duchenne's muscular dystrophy. So somebody asks you, Duchenne's muscular dystrophy patient have cardiomyopathy. So it is usually dilated cardiomyopathy, and the gene is dystrophin, and then it is an X-linked inheritance. Okay, so these are inherited patterns of dilated cardiomyopathy, but we can have acquired causes also, which you very commonly remember. You already know, we remember it as MPT. Okay, MPTS. Okay, MPTs. Okay, so remember, M is for myocarditis. So it is usually associated with myocarditis. So post myocarditis, we usually have dilated cardiomyopathy. P is peripartum. Okay, so peripartum cardiomyopathies are also dilated. Okay, then T is for toxic. Toxic is usually alcohol. So post alcoholism also we can have dilated cardiomyopathy. Okay, also you have to remember even one more toxic is hemosiderosis. So in hemosiderosis, most common cardiomyopathy is dilated. Okay, so it can have restricted also, but dilated is more common. Okay, then we have supraphysiological stress. So whenever we have supraphysiological stress, excessive stress, then we can have dilated cardiomyopathy. Like, for example, if I'm saying what is one of the supraphysiological stress, like infants of insulin dependent diabetes mothers. Okay, infants of insulin dependent diabetic mothers usually have a lot of supraphysiological stress, so they can have dilated cardiomyopathy. Or catecholamine overdose. Okay, so in this regard we have a cardiomyopathy which is Takotsubo cardiomyopathy, which is also called as broken heart syndrome. Okay, broken heart syndrome. So this Takotsubo cardiomyopathy is called broken heart syndrome. It is basically due to extreme stress. Okay, so if you are extremely attached to somebody and he or she leaves you, okay, so there is a lot of stress, catecholamine stress that occurs. So what happens in that case is that left ventricular contractile dysfunction occurs. Okay, so left ventricular contractile dysfunction occurs, and typically the apical part of the left ventricle bulges out. So it appears like an octopus trap. Because tip is is bulging out and the left ventricle contractile dysfunction occurs. So this is called Takotsubo cardiomyopathy, and this again comes under the category of dilated cardiomyopathies. Okay, so everybody should be very, very clear with this. So remember, dilated cardiomyopathy, 50% of the time it is familial. Most commonly inheritance is autosomal dominant, and in that also we have Titan mutation, particularly associated, especially if they have ninja star nucleus in more than 5% of the cells. It can also have mitochondrial inheritance in pediatric age group and X-linked inheritance in puberty. Okay, acquired, it is MPTS. Okay, so it can be myocarditis, it can be because of peripartum, it can be because of toxic alcoholism, or it can be supraphysiological stress like infants of the diabetic mothers, or catecholamine overdoses. Okay, hyperthyroidism. Okay, so any supraphysiological stress can cause dilated cardiomyopathy. So if you look at this diagram, okay, so this is a diagram of all the cardiomyopathies together. If I'm looking at the dilated cardiomyopathy, you know, dilated cardiomyopathy is a systolic dysfunction, and you can see this nucleus here. These are ninja star nucleus, which should be present in more than 5% to call it as a dilated cardiomyopathy. Okay, to call it as a Titan mutated dilated cardiomyopathy. Now, when we talk of HOCM, okay, so hypertrophic obstructive cardiomyopathy, you remember 100% of it is genetic, and I have told you a story also of a very typical example which happened in our college time. So this is 100% genetic, and the mutation usually is of beta myosin heavy chain, or this is also beta myosin heavy chain is most commonly implicated, or myosin binding protein C can also be implicated in this. And the typical effect is that usually the cavity becomes banana shaped and the septa becomes very, very thickened. So there is asymmetrical septal hypertrophy and the cavity becomes banana shaped. And the histological features are very, very characteristic. Okay, so that is what you have to remember. The characteristic point that you have to remember is, first, there is hypertrophic cardiac fibers. So if you look at the thickness of all the cardiac fibers, they are usually 40 micrometers. Okay, so they're quite thickened, they're more than 40 micrometer, and all of them are going haphazardly. Some are going like this, some are going like this. So there is a disarray. Okay, so this array, okay, some are going like this, some are going like this, so they are not aligned to each other. Alignment is very important for the heart to be together. So there's a lot of disarray, and there is interstitial fibrosis also in between. So there is thickening is increased, there is haphazard arrangement, and there is interstitial fibrosis. So these are characteristic 3 features of HOCM which all of you should remember. Now, once we are clear with this, in restrictive cardiomyopathy, whenever they are giving you, there is something which infiltrates. So these are the cardiac muscle fiber, and pink material you can see in between the heart fibers. This is a myeloid, and if you look at, if you put Congo red stain and see it under the polarizing microscopy, you will see this apple green birefringence. So this is restrictive cardiomyopathy due to myeloid. Okay, so that's very, very clear, which you should be knowing. Okay, so these are 3 cardiomyopathy images together which can be asked you in your exams. Okay, so that's your cardiomyopathy questions which you should remember. So ninja star was an update that came up in the Robbins new edition, so everybody should be super clear with that, right? Okay, so let's come to the next question. So this is sweat, chloride and pancreatic levels of chloride in cystic fibrosis. What are they? Okay, so basically they want to know the sweat and the pancreatic levels in cystic fibrosis. Okay, the options might be different in your exams, but your concepts should always be same. Okay, so whenever we are looking at cystic fibrosis, some things should be very, very clear. Okay, so what happens in cystic fibrosis is, whenever I'm talking about cystic fibrosis, remember everything in cystic fibrosis starts with C. Okay, so C or C like voices. So basically the defect here is in the a gene called as CFTR. Okay, so this is cystic fibrosis transmembrane regulator. It's actually transmembrane conductance regulator. Okay, so this is a gene which is present on chromosome number 7q. Okay, so 7q. So this cystic fibrosis transmembrane regulator is a very, very important regulator. To understand this, let me give you an example. Okay, so let us say this is the skin. Okay, so let us say this is the skin of an individual. Okay, so this is the skin of an individual. Okay, so normally if this is the skin has to be lubricated by the sweat glands. So these are the sweat glands which are present in the skin. Okay, so all these sweat glands have, you know, some channels in this, which is very important for the sweat secretion, because we don't want excess salt to be secreted from our body. So to maintain that, there are some channels on the sweat, okay, on the sweat glands. So this pink one which I'm drawing are basically, let's say, these are your CFTR channels, which basically deal with chloride conductance. Okay, so the major function of CFTR channel is in chloride and bicarbonate. Okay, chloride and bicarbonate. Okay, so in the skin, basically these pink channels are dealing with chloride transport. So their function is to transport the chloride, okay, outside. Why? Because sweat glands make a lot of chloride like this. Okay, so chloride is a negatively charged ion. You can see there's a lot of chloride. Apart from that, skin also has a lot of sodium in it. Okay, so sodium is a positively charged channel. Okay, so positive and negative attract with each other, so these positive want to stay with the negative only. So to maintain the exchange of sodium, we have a separate channel here, okay, which is called ENaC channel. Okay, so these are ENaC channel which basically deal with the transport of sodium. Okay, so normally what happens is whenever there is an excess secretion, we are exercising, we are running, so these sweat glands are stimulated and they secrete a lot of sodium chloride. But we can't let all the sodium chloride go out into the skin, because anything which comes out into the skin is wasted, it goes out, isn't it? So it has to stay in the body. We don't want water, because sodium is very closely linked with water. If sodium goes out excessively, water goes out excessively, we don't want that. Okay, so what does this channels do is, CFTR channel is basically dealing with the chloride. Okay, so as soon as excess sodium chloride is formed, the chloride is taken out from the sweat glands by CFTR, and sodium is taken out by ENaC channel, and sodium is taken out by ENaC channel. So that is how the sodium and chloride are washed off, and only small amount of sodium chloride goes into the skin. And sodium chloride is the normal salt, so that is why our sweat is usually salty. But we don't have excessive loss of sodium chloride, because otherwise it will become excessively salty sweat. That doesn't happen normally. Now, what happens in patients with cystic fibrosis is that these CFTR channels are defective. Okay, so they are not working. Okay, before we go to the defect, I should tell you the normal function of CFTR. One more normal function of CFTR. So yes, we have talked about these CFTR channels. Okay, so these pink color channels here. Normal CFTR channels, also what do they do is, they basically have the function of blocking ENaC channel. Okay, so whenever these normal CFTR channels are working, their function is they block ENaC channel everywhere in the body. Okay, so they block ENaC channel everywhere in the body except sweat glands. Okay, in sweat glands they don't do it. Okay, both of them go together out, together in. Okay, so apart from sweat glands, everywhere in the body, the CFTR channels have the major function of blocking ENaC channel, except sweat. Okay, in this doesn't happen. Okay, now let's see what happens when the CFTR channel gets mutated. Okay, so I'm saying that CFTR channels are mutated. Now these CFTR channels are mutated, that is, they're lost. There is no CFTR channels. We don't have any CFTR channels now. They're lost, they're mutated. So what is going to happen is the chloride is not going to go out. Okay, chloride is not going to go out. Okay, chloride is not going to go out. It's going to stay here only. So there will be a lot of chloride here. So I'm going to draw, let me draw this here. Okay, so this pink one is your skin. Okay, and these are your sweat glands, let's say. Yeah, so pink one is chloride, as I have already told you. This is a lot of chloride here, lot of chloride. And let us say sodium is blue. Okay, so this is sodium and chloride. Okay, this is excessively produced. Now what happens is CFTR channels are blocked. Okay, so that is, they are closed now. Blocked means they are defective. Defective CFTR channel means they are closed gates. They are closed. Okay, so this is CFTR. So this is CFTR. It is, the gates are closed. The gates are closed. So chloride cannot go out. Okay, so all this chloride remains here. Okay, all this chloride is coming to this skin. Okay, there's nobody who's going to take them out. Okay, so I told you, everywhere in the body, the normal CFTR controls the activity of ENaC. Okay, that is sodium channel, except in the sweat gland. In sweat glands they don't. Okay, so obviously what is going to happen is that normally the ENaC channel is going to take. Okay, so this is the ENaC channel. Okay, so let me draw it in blue. Yeah, this is your ENaC channel. Okay, ENaC channel, what is it going to do? ENaC channel is going to take the sodium out. Okay, so this basically, so what does this CFTR do? It does opposite work here. It blocks, so normally normal CFTR should block the activity of ENaC. Here the defective CFTR blocks the activity of ENaC. Okay, so it says no, I am here, so sodium should also not go out. So it doesn't allow sodium also to go out. Okay, because it decreases the activity of ENaC also, decreases the activity of ENaC. So all the sodium also now stays in the lumen. Okay, so sodium also stays in the lumen. So all this sodium chloride together now comes into the skin. All this sodium chloride now comes into the skin. So what happens? That's the typical complaint the mother of the cystic fibrosis patient says. The sweat seems very salty. Okay, salty sweat. Okay, so that's a very classical history that a person from the cystic fibrosis mother says the sweat is very salty. The kid has salty sweat. This is because all the sodium chloride stays there, comes out into the skin, and your skin is very, very salty. Okay, so that happens in the sweat. Okay, in the sweat. So ENaC activity is actually decreased here in the sweat. Okay, so that is why sodium also goes out with chloride together. They say, okay, we both will go out and we form salt. So that's what happens in the sweat glands. Okay, so ENaC activity is closed. The chloride channels, the chloride concentration in the sweat is increased, and that is why we do the test also. So if you see the chloride concentration in the sweat in these patients of cystic fibrosis, it will be increased. So chloride concentration in the sweat is increased in cystic fibrosis patients, and that's how we pick them up. Okay, now, but what happens about the rest of the organs? So these CFTR channels are present all over the body. Okay, so all the glands, all the secretions are, all the organs have the CFTR channel. Now problem arises in your respiratory mucosa, in the gastrointestinal tract, and in the pancreas. So what happens in the lungs? Let's say these are the lungs. Okay, so these are the lungs basically. So in lungs, what do we need is, we need these CFTR channels. Okay, so these are the CFTR channels. Okay, so here the function of CFTR channel is to give chloride into the bronchus, into the lumens, so that it can maintain the moisture. It can maintain the moisture. So that is why the chloride channels basically pour in the chloride. It pours in the chloride into the lung and the mucosa. And you already know that wherever CFT are present, along with that we also have ENaC channels here. So normal CFTR will block the activity, will decrease the activity of ENaC. So normal CFTR will block the activity of ENaC, so that sodium which is present inside does not go out. Okay, so sodium cannot go out. So what happens is, when sodium cannot go out, water also remains there, and all the secretions remain moist. All the secretions remain moist. So there is a lot of sodium and water in the secretions, and that is why, because the secretions are now moist, so what will happen is the cilia can beat properly. The cilia can beat properly. Okay, so cilia will be able to beat properly. So now let's see what happens in mutated. So let's look at the bronchus here. Okay, so let's say this is the bronchus, normal bronchus, and here we have cilia which is beating. So cilia require a lot of water. So I told you here that we have two channels I'm drawing. Okay, so we have CFTR normally. So I'm drawing a normal bronchus, and then we're going to talk about mutated bronchus. Okay, mutated bronchus. Okay, so when we're talking about normal, so this is CFTR channel. Okay, so CFTR channel and the sodium channel. So CFTR channel normally blocks the activity of ENaC. Okay, it will decrease, so that sodium remains in the secretion. Along with that, water also remains in the secretion, so that cilia are able to beat properly. Secretions goes on. Okay, so cilia are able to beat properly, and normal chloride is also secreted. Normal chloride is also secreted into the secretions, so that it's remaining like that. So cilia is beating properly. Now what happens in the person, let's say, so in your cystic fibrosis patient, this is blocked. Okay, so what happens is, now this is blocked, so the calcium cannot come inside, and it cannot block the activity of ENaC also. So it cannot block the activity of ENaC, it cannot come into the secretion. So what is going to happen? All the sodium will keep leaving, okay, will keep leaving through the ENaC channel, and water will also keep on leaving, okay, water will also leave, sodium will also leave. So this secretion will become thick and viscous, okay, because water has left, okay, water has left, sodium has left, and chloride is not, chloride is also blocked there. So because the chloride is blocked there, it's not going out, sodium and water are excessively leaving out, the secretions becomes thick and viscous. So if you look at these thick and viscous secretions, what will you find is that the sodium content of these secretions are very, very less, they are dehydrated. Okay, so that is why, because they are thick viscous secretion, now cilia cannot block, and there will be a lot of mucus plugs which will be formed. There will be a lot of mucus plugs which will be formed. Now, the main problem in pancreas, if you look at that main problem in pancreas is because of these CFTR channels not only maintain the chloride transport, it also maintains the bicarbonate. Okay, so bicarbonate is very, very important, because bicarbonate basically maintains the secretions basic. Okay, so it gives the basic component to the secretions. So when the CFTR does not work, the bicarbonate is not secreted, so the secretions become acidic. So when the secretions become acidic, it helps in forming more mucus plug and more growth of the organisms. So there's a lot of growth of pseudomonas. So pseudomonas and organisms grow more, okay? And there's formation of more mucus plugs, and more infections, and these patients have pancreatitis. So main cause of pancreatitis is that bicarbonates are not getting secreted through CFTR. That's the main problem in pancreatitis. Okay, so now can I see this diagram? So I have already told you that normally the ENaC is normally inhibited by CFTR. The exception is sweat glands, and this doesn't happen. In all the other organs it will happen. So normally if you look at the airway, so this is the secretion where the cilia have to beat like this. Okay, so the chloride goes inside, and normally this will basically inhibit the function of ENaC. So sodium will not be able to go out excessively, so this remains there, and water also remains there, so the secretion becomes your watery, and the mucus are able to beat properly. Look at the cystic fibrosis patient. There is no CFTR channel, so chloride is not secreted into the secretion. Chloride doesn't come into the secretion. Okay, secretions don't have chloride now. And again, because this normally should inhibit the function of ENaC, so it doesn't inhibit the function of ENaC, so sodium is keeping on going out, and along with that water also keeps on going out. Okay, so because water is going out, sodium is going out, so what will happen? The secretion will become dehydrated. So if you look at the concentration, if you take this mucus and see, the sodium content of this mucus will be very, very less, and the chloride content will also be very, very less. So the chloride content will be very, very less in the bronchus, in the secretions. Okay, so that's very, very characteristic of cystic fibrosis. Okay, so remember always, in the sweat the chloride concentration is increased, whereas all over the body the chloride content is decreased. Okay, chloride content is decreased. Okay, only the sweat is salty, the other areas are not salty, they are thick. Okay, so this is because the chloride channel is not working, and sodium is excessively taking out water. Okay, whereas in sweat gland, I told you this function doesn't work. Okay, so in the sweat glands what happens is both CFTR and ENaC resorbs water, so the normal salt content decreases in the skin, whereas what happens is when the CFTR is blocked, okay, so ENaC basically the effect is not like on other organs of the body. So here when the chloride is not getting absorbed, sodium also doesn't get absorbed, and both remain together, and therefore the secretion becomes very, very salty. Everybody clear? So can I remember it in that way? So in a block if I'm drawing, okay, so sweat is salty, chloride is high in the salt. Okay, in the other organs, especially the bronchus, okay, the chloride is less, the sodium is excreted out, so there is thick secretions. The main cause of pancreas is not working of bicarbonate channel, which is through CFTR only, and that is why the secretion in the pancreas are acidic secretions. And there is a main problem here is the infection by pseudomonas is very common in patients with cystic fibrosis. So that's the crux of the story of cystic fibrosis. So the question you have to remember here, okay, so somebody asks you what happens in cystic fibrosis. So you all know now the chloride channel is decreased, okay, so chloride transport is decreased in the sweat, and therefore there is salty secretions. What happens in pancreatic secretions? Again, the chloride concentration, if they're asking, chloride concentration is decreased in pancreatic secretions. So chloride concentration is decreased in pancreatic secretions. So it must be a multiple choice question, or I don't know what are the correct options that you should remember. So you should be very clear with what you are seeing. Okay, so in cystic fibrosis, the sweat is salty because the chloride transport is decreased. So chloride remains in the lumen itself and is secreted to the skin. In pancreas, basic problem is with the chloride transport along with the CFTR. Chloride transport becomes defective, and that is why the secretions become acidic. In the respiratory mucosa, the chloride secretions are not seen. CFTR channel is blocked. Okay. Apart from that, this CFTR cannot block ENaC channel. So therefore, sodium resorption continues. Sodium is continuously being resorbed along with water. So the secretions become very thick and viscid. So that is the classical feature of cystic fibrosis. Remember, cystic fibrosis is an autosomal recessive disorder, which you should be very clear with, right? Now let's come to the next option. Okay, so in a known case of rheumatic heart disease, there is dyspnea. What is the correct method of collection of blood sample to diagnose infective endocarditis? So this was a very tricky question, guys. Okay, but you should remember that if I talk about the American heart guidelines, they say that okay, to make a confirmative diagnosis of infective endocarditis, you need 3 blood cultures. Okay, 3 blood culture sets. You have to remember, sets means you have to take 1 bottle for anaerobic and 1 bottle for aerobic. So you need 3 culture bottle sets to make a confirmatory diagnosis of infective endocarditis. Okay, if suppose you are taking 2 culture bottles, it will not be confirmatory, but it will make a probable diagnosis. If you are taking 2 culture bottle sets, you can take them, but then the 2 samples should be at least 1 hour apart. You have to take the 2 samples at least 1 hour apart. So if we look at the guidelines, if you're looking at the guidelines says you have to take 3 blood culture sets from a separate venipuncture sites prior to antibiotics. Volume of the sample should be 10 ml in every bottle, because you're taking set. So 2 bottles, 1 anaerobic, 1 aerobic, and there should be at least be 1 hour interval between the first and the last row. Then only you can make the diagnosis of your infective endocarditis. Okay. Apart from that, if you look at the modified Duke's criteria for the diagnosis of infective endocarditis, you should be very clear that we require either a pathological criteria or a clinical criteria, first of all. Okay. If we talk about the pathological criteria, either we demonstrate microorganism by culture or histopathologically, or if we take active vegetation and we do a histological confirmation, then also we can make a diagnosis. If you're looking at the clinical criteria, guys, you should be super clear that we require 2 major. That means either the blood culture should be positive for a characteristic organism. So characteristic organism, if you're suspecting, even if you're taking 2 culture bottle sets, you can make a diagnosis. But for an unusual organism, if you're doing, you need a 3 culture bottle sets. So basically, ideally, American Heart Association says you need 3 culture bottle sets for making a confirmatory diagnosis of infective endocarditis. You require 3, and the time interval between these should be at least 1 hour. Okay, or you should document it by echo, or you should have a new valvular regurgitation, which you can identify by various techniques like PET. Okay, apart from that, we have a minor criteria which you already know, that there should be a predisposing heart lesion or patient should be an IV drug abuser. And apart from that, you all know that patient should have a fever should always be there. Okay, and then VIM. Okay, what is VIM? Vascular lesion, immunological lesion, and microbiological evidence. Microbiological evidence means even if there is a single culture which is positive for unusual organism, it is considered as a minor criteria. Okay, so fever is one of the minor criteria. Okay, so remember, there should be a either previous heart lesion or IV drug abuse. Fever should be there, and VIM Patient should have Vim. Okay, right. So whenever we are making a diagnosis, we require either 2 major, or if we are using 1 major, we require 3 minor, or we should have 5 minor criteria. Okay, so to make a diagnosis of infective endocarditis. Now let's come at the question. So the question was that what is the correct method? So ideally you should have 3 samples from a different venipuncture site. Okay, if you're taking from 2 from periphery, 1 from central, it's okay. Okay, if you go by option 1 sample from peripheral and 1 central, 30 minutes is not, at least 1 hour, or at least 1 hour difference should be there. Okay, urinary catheter not there. Intravalve clot means what? If you're doing it and you're doing a histological examination and you find a characteristic organism, then yes. Okay, but they're asking about collection of blood samples, so I think option C is correct. You require 3 culture bottle sets from different venipuncture sites, right? So that is how we make a diagnosis of infective endocarditis. Is everybody clear with that? Okay, so with that we finish the recall options of this paper, right? I hope you've understood this, right? Okay.